referred to as the Prescription Review Program, which I think the executive feels better captures the ethos and objectives of the program. As you know, the program had previously been launched in where the board reviewed data from the 2012 and 2013 calendar years. In relation to those calendar years, they received 2,694 deaths were reported from the CDPH. Now, we're about to be relaunched in relation to the year 2019, and I can report that the executive has just received death reports from the CDPH in the number of 2,666. So basically 2,600 in relation to 1 year when it was approximately the same in relation to 2 years. So this represents almost a doubling of the death report. So that obviously is a serious cause for concern. Now, the board has learned from an experience with this program, and as set out in the memo, we have set out a more robust review process in terms of examination of the cases, which is limited not only to an examination of the circumstances of the death, but then looking to the entire prescription profile of the physician using the cures system. If there are serious concerns, there is a further review and a review of actual patient records and medical records dealing with a whole series of issues. And only then at that point, in terms of a second review, if there are serious concerns, will we go to an investigation. So I think we have a much more robust approach in terms of what will be done prior to investigation, which I think will address some of the concerns of the previous report. We're now only looking at very recent cases, so we're not going to run into issues in relation to the statute of limitations. And as I said, we do have a concern that at least at the initial stage, the death reports appear to have doubled from where they were before. So the team is looking forward to working this issue. And obviously the goal remains the same, which is patient protection, consumer protection.
Thank you. Do we have any comments or questions from the members regarding the death certificate project with its new name?
Bill Devganidev. So I'm so glad that you changed the name.
Yeah.
It just was miserable to hear this death certificate name project, but it's surprising that you have doubled the number. Have you? Do you have any idea why it is? I'm just curious because I expected the numbers to, well, I mean, it is from probably 17, 18, 19, so that's why maybe it's different because the prescription drug overdose deaths have been decreasing in California, so I'm just curious.
Well, okay. Well, we have only recently got the death reports in. So our team are analyzing that now as we speak. I think there are some indications that there is a high percentage of the deaths which are related to street drugs. But I mean, this will require very careful analysis. But the fact that there is effectively a doubling of the deaths reported is obviously a cause of great concern.
Yeah, that explains, because the biggest problem now is the growing demand or growing the use of illegal fentanyl coming out of China. So that's why I was just curious to learn that why the numbers are up. And you explained to me that the non-prescription drug deaths are increasing. Thank you.
Okay.
Any additional comments or questions from the members?
Ms. Bynes, this is Dick Thorpe.
Dr. Thorpe?
Well, thanks, Bill, for that update. I am also surprised that the rates have doubled because, at least in the community, it is increasingly difficult to find, and it has been for the last several years, to find physicians who are even willing to prescribe opiates in the broader community. I don't know what it's like in the urban community, but I know in many of the rural communities in Northern California, it's very difficult to find someone who was actually willing to write those prescriptions. So it does make me question what the source of those deaths are more carefully, I guess. Anyway, I guess that's my only point, is that at least in the community, it seems like it's one of the concerns that I know that we've had is that people who are being taken off opioid narcotics abruptly, like like Dr. Waller was telling us earlier, those people become desperate, and then many of them actually do go to the street to look for other sources of opioids rather than a more controlled way of getting their medications, and a more not trying to say that opioids are the panacea for everything, but I'm just saying that there is a reality where people who are denied medication look for other sources, and some of those sources are extremely unsafe, of course. Thank you.
President Pines?
Yes.
An additional comment, and I think it's to Dr. Thorpe's point, and it's also being mindful of the presentation on pain management that we received earlier today. I know that the original impetus or the thought behind this program originally was that we would be looking for those physicians who were behaving badly across the state, and perhaps as we look more into what Bill has reported is what looks like the preliminary data here. I mean, perhaps we modify or transform this program in some way such that it's not just a disciplinary or an enforcement program, but one where we can do some education of our constituent physicians and then also of the public as well. So I would just encourage us to look at modifying the scope of this, of this program as we move forward and dive into that new data.
Thank you. Any additional comments from members? Okay, Sean, let's move to the public. Comments from the public?
We'll open up the Q&A window, so if anyone would like to make a public comment, please indicate so now. First up, we have Yvonne Chung. Yvonne, are you there?
I am, thank you. I'm Yvonne Chung with the California Medical Association. CMA has had concerns with this project since its inception, and physicians have reported that receiving a letter from the medical board indicating that a complaint has been received and is being investigated is highly stressful and disruptive to their practice. And this experience can lead to fear and mistrust of the medical board's disciplinary process. We do appreciate that the board is recognizing that the current process of identifying physicians data and analyzing the names may not be sufficiently targeted, and it could result in a significant number of physicians receiving letters requesting patient medical records who are subsequently not found to be practicing outside of the standard of care. We do support revising the process of how physicians are identified. We encourage the board to work with an independent entity such as the California Research Bureau or a consultant like Dr. Waller, who presented earlier, to review the process for identifying physicians who are prescribing opioids in a manner that represents a departure from the standard of care and merit further investigation. This review, with input from stakeholders and subject matter experts, would likely result in the identification of specific changes to the project methodology and the use of different risk factors that more accurately identify physicians. Finally, since this project is not mandated by statute and in light of the board's financial issues, we do recommend tracking the costs associated with increased investigation and enforcement, so an assessment can be made to determine whether or not the outcomes are justifying the resources expended and if the project should be continued or modified. Thank you.
Thank you for your public comments. Next up, we have Marion Hollingsworth. Marion, are you there?
Hello, can you hear me?
Yes, please go ahead.
Thank you. Good morning. Actually, good afternoon now. My name is Marion Hollingsworth, and I'm a patient safety advocate. First, I'd like to thank you for having an update on the death certificate project. I had asked the board several times over the last year for an update since it seemed that this program had stalled. I'm glad you have taken it up again, even in a revamped version, because it will ultimately help to save lives, especially with this new robust review process. My concern is that the first round of the project was in 2012 to 2013, and that this new second round will only look at overdose cases beginning in 2019. That is a 6-year gap. A lot of overdoses will be overlooked, leaving a number of dead patients and grieving families without accountability. The project started out like gangbusters, but it seemed that when the CMA claimed how unfair it was, you not only backed off, you also backed down. Notice how quickly the CMA members on the board and the CMA official weighed in on this issue today. Also notice that the majority of disciplines for these overdose deaths have been reprimands. I understand laws regulating prescribing have changed since 2012. However, skipping 6 years seems like a terrible idea, one that will no doubt leave a number of overprescribing doctors in practice with no oversight. From reading over disciplines in your alerts, there is no shortage of doctors who routinely overprescribe. Finally, changing the name from the Death Certificate Project to the Prescription Review Program really takes the air out of it. The new name loses urgency and clumps the project in with just any prescription, like one for a rash or a cough. When I would talk to reporters about the Death Certificate Project, just the name alone would pique their interest, and they would want to know more about it. Prescription Review Program sounds boring and benign. Seriously, it sounds as interesting as counting pills. Was a name change made to make doctors feel better about themselves if they get caught up in it and investigated? If you want media attention for this project, you should keep the original name or come up with one that will be more adequately describe it, thus garnering more attention. While I applaud the return of this project, it feels as if you are trying to make it as benign as you can so as not to upset the doctors and the CMA. You need to be more assertive with this project, or else the doctors will not respect it or be prompted to make changes in their prescribing to avoid being swept up in it. Thank you.
Thank you for your public comment. Next up, we have Rosie Arthur's daughter. Rosie, are you there?
Yes, I am.
Please go ahead.
Thank you very much. When I learned about this project, I was immediately concerned, and it sent up a lot of red flags for me as a researcher and analyst. There's a number of better ways, more efficient ways, more ethical ways to approach this problem. First of all, you have to really define what the problem is and how you design the research. And right now, the way it is, it's digging into patient-privileged information, doctor-privileged information, when there are better ways to accumulate that data. And as an unintended consequence of this whole process, once notices go up, once somebody gets a letter from the medical board or whatever, patients that they are treating rightfully or wrongfully or however suddenly find themselves without appropriate treatment. Sometimes being abruptly discontinued, etc. Now, the CDC has already defined this. They've already written a report in the study and found the reason for this, it was not unexpected, was fentanyl on the street, just as this was stated before. When these new rules went into place, we anticipated that there would be an increase in the deaths, not a decrease. So this isn't new news. There's really nothing there to discover that's news. What needs to be done is to look at how structure and how the board responds to it, what the education is. General practitioners, specialists, pain specialists particularly, are poorly educated on the problem. And everybody loses in this situation. Now, I've been a whistleblower before, so I'm not on one side or the other. All I want to see is that the problem gets approached in a purposeful manner that's ethical and doesn't end up injuring people as a result. And that seems to be what's happened, is we've got a rate double for people who are suddenly receiving less than adequate care and look to the streets to get it. And the CDC has already looked at it. So all you have to do is pull up the
15 seconds
report.
remaining.
Okay, thank you.
Thank you very much for your public comment. Next up, we have Eric Andrews. Eric, are you there?
I'm here.
Go ahead.
See, this is so typical of Yvonne Chung and the CMA. See, this is what we've been telling you guys about the CMA. An organization that does not speak for all of California's doctors, as only 1/3 of them belong to this club, and a good portion of those are forced to join by their local medical associations. So don't give the CMA more weight than they deserve, because they don't speak for all of California's doctors. Their concern is only for the poor little doctors who might get snagged for their wrongdoing, not for the huge patient safety protection the DCP provides to the consumers of this state. The information on death certificates is not private. The patient is dead. There's a bigger issue of doctors harming more people after someone dies than their privacy after they're gone. And I have no problem with the death certificate project name. That's just silliness. It uses death certificates, and it's a project. It's perfectly named. Thank you.
Thank you for your public comment. At this time, I do not see any additional question queue.
Okay. Great. Thank you, Mr. Pacifica, for leading us through that. This is very important. Moving to agenda item 22.
Time to speak.
Yes.
Dr. Hawk, maybe this would be a perfect time to send the board information about the process. Actually, I'd like to see it again, about the procedure, the process that's used for the study. I'd like to receive it.
Okay. We have staff send that out to all the members.
Ms. Pines.
Yes, Dr. Thorpe.
Thank you. I really appreciate the fact that we've had a serious conversation about the problems and the challenges of chronic pain today. It's been really, I think it's been eye-opening for all of us. It's been really helpful for all of us. But it clearly points out that the issue that we have a serious problem in, we have a few, as Dr. Waller pointed out, relatively small, 1% is what he estimated, that were actually malignantly prescribing medications in a way that was unethical. And we clearly have an obligation to find those people and make sure that doesn't happen anymore. I'm totally on board with any of that. The challenge is, how do we approach the bigger problem of, on the one hand, not of educating our population of doctors, mostly primary care doctors, because we don't have enough pain specialists in the state to actually functionally manage these patients. We don't have enough addiction specialists. We don't have enough psychiatrists. We don't have enough interventional pain people to actually manage these patients. It's mostly done by primary care. And how do we educate primary care, our workforce, in how to effectively manage a large population of people who are already on large doses of narcotics, and some of them on narcotics and benzodiazepines. So it's a challenging problem. Dr. Hawkins and I have probably know more about that than anyone who kind of deals with it on a day-to-day basis. It's a challenging problem, and it's not easily done. And when you're in a primary care practice where you're seeing 20, 30 people a day trying to manage multiple problems, in the middle of that, to have a patient who has not only chronic pain, but diabetes or hypertension or coronary disease, and trying to manage the whole person, to sit down and have that kind of conversation that's a quality conversation like Dr. Waller was talking about, is extremely challenging. So we, as a board, I think, have an obligation to our licensees to find a way to have the conversation in a meaningful way, to educate them, so that we, on the one hand, don't just blatantly cut everybody off of their pain medications or their benzodiazepines, which is clearly dangerous. And on the other hand, we don't enable people who don't need the medication, and we do it in a way that's safe. And so we don't make the mistake of enabling doctors who are overprescribing to harm patients, and yet at the same time, we educate doctors so that they can identify the patients that need to be tapered off and find a way to continue to manage what patients they do keep on medications in a safe manner. That's a very serious problem, and it's a big problem that needs to be solved. And I think that we need to have a consistent approach to that, not just the death certificate project, but a larger role to play in how to help manage that educational process. Because Dr. Waller really didn't have an answer about how do we educate our I don't know how many primary care docs there are in the state of California, but probably 50, 60,000, something like that. There's a lot of people to educate about how do we manage this problem. So I think that's something that deserves time and energy and resources to ensure that we don't make our mistakes. You know, in the past, we've made the mistakes of saying, well, everybody gets whatever pain meds they need. That's clearly the wrong approach. And now we have this very restrictive policy where doctors are afraid to write pain medications because of the death certificate project. We need to find that middle ground that Dr. Waller was talking about. And I think the board has an opportunity here to really do something very positive, both for the public health of California, for consumer protection, and to help educate doctors to do a better job.
Thank you, Dr. Thorpe.
Denise, yes, to just jump on that point again that Dr. Thorpe has made. All of this, the death certificate project, from my understanding, it identifies some of the doctors who may have been, after the consultants determined that they've overprescribed, they've outside of the standard. So there's the identification. Dr. Waller explained today that most of those doctors need the required education. So when I'm listening to the comments, I'm saying, if we don't identify, because that's the only way we can identify them right now. So we need to identify them via the death certificate project. What I do agree with Dr. Thorpe is then after that, there's the opportunity to not let the disciplinary process be so, like the way it is. We need to reimagine what that would look like so that it can create a rehabilitation and education of these doctors. And I think what they perceive this as now when they get these medical letter from the board is that I've done something wrong. So it spikes the fear. And when the fear is spiked, it's only because there's not a lack of education. I don't even know what I did wrong. And so it just all points to, once we identify it, there is an opportunity that we need to communicate that this is not to take you out. This is to educate you, unless it's so egregious that some of the cases are going to be egregious, but it's the middle that Dr. Waller was talking about. We are interested in that group of people. And I just think the death certificate project provides us opens the door to that for us to come in and address these issues in a different way, based on what we know now after today's presentation. Thank you.